So I'm here today recording with my very old friend and colleague, Rani Lill Anjum, who lives in Oslo or near Oslo. And Rani is a researcher of philosophy at the Norwegian University of Life Sciences. Hi, Rani. It's so lovely
nice to be here.
Yeah.
Very nice to be here.
Yeah, it's lovely to see you. And so Rani is an expert in causation. She is a philosopher who's studied logic and causation for many years, and in more recent years has looked in a great deal of depth at causation in the context of healthcare. So I've invited Rani to come and have a chat with me today to talk a little bit about causality and causation in healthcare, since that's what we're looking at the moment. So Rani, as we are both philosophers, and I think it's really interesting to look at the sort of the basis of the concepts that we use in bioethics particularly. So I'd be really interested if you could give us a little introduction to Hume's account of causation, which one of our readings this week has looked at that a little bit. But if you could explain that and its influence on how we understand causation in healthcare.
Yeah, so this is really half of the work I do, is to explain Hume. So David Hume, he was what we call an empiricist philosopher, which meant that the only thing that he would trust as knowledge is what we can observe through our senses. So if we cannot observe it through our senses directly, we would have to speculate. So it's like, if you think of in science, for instance, the relationship between data and theory, he would definitely side with the data. He would say the observation data is what you can trust because that's your evidence. And the theories explaining the data, that's speculation, because you can have different types of data. But for any type of data, no matter how good they are, there would be infinitely many theories that could explain them. So how do you know you have the right theory? So definitely that's not something he would trust. So when he was looking at cause and effect relationships, he was saying the same thing. What can we observe when it comes to cause and effect? And he said, well, if you think of a typical case of cause-effect relationship, it's when you play billiard ball or pool. So you hit a ball, and that ball should hit another ball, and after it meets the other ball, the second ball should start rolling. And he said, this is a typical example. And of course, normally we think that there's some kind of forces underlying, Newtonian forces that happens in this meet. But he says, this type of forces, it's not like we can observe them. But what we can observe is that every time one billiard ball hits another ball, the second ball will start rolling. So if you do it in the same way, the same thing should happen. So it's this type of perfect regularity. So that means that what you have to look for when you look for cause and effect is actually to start with correlation data. So you start by looking at correlated events, but you don't know what is the cause, what is the effect. So that's why he says, first you have to, what happens first is what you call the cause, and what happens next is what you call the effect. So you need to look for temporality. So if you have pure correlation data, you don't actually know the direction of the causal relationship. And then, of course, it says you cannot just have correlations and regularities. You have to have them in the same space and time. So, for instance, if I take a paracetamol and your headache goes away, I mean, it is a kind of, it could be a kind of regularity, but it's not the same time and place. So that shouldn't count as causal. So from this pure empiricist conception, he says, no matter how many times you've seen something like irregularity happening, you don't know if it will happen the next time. So in order to know what would happen the next time, you would have to be able to observe some kind of necessary connection. So for instance, such like a law of nature. But because a law of nature is not observable, he would just dismiss that. So what people have said is that it is a problem with the empiricist starting point. If you can only say what you can observe, you have never observed the future. So any prediction is going to be ungrounded in the data. So it's always going to be a leap from your data to saying that, and outside the data, the same thing is going to happen. So what you need then, you need to have as much data as possible. So ideally a perfect data set.
Yeah.
But you can see how that's a problem.
Yeah.
It's not going to happen in medicine.
Yeah. And this, like that Humean kind of empiricist approach to understanding causality, that kind of is instantiated now in the Bradford Hill criteria, isn't it, for how we move from correlation to inferring causality from many instances of correlation. And
yeah, the Bradford Hill criteria are interesting because they have some Humean criteria that are empiricist and some that are not.
Oh, okay.
Because it also includes things like plausible mechanism, plausible theory.
Yeah.
You know, so why exactly did this happen? That would go beyond the Humean.
Right. Yes.
So
yes.
The Bradford Hill criteria seem to be a bit more pluralist. It seems to rely on different types of concepts. I could show you the model of causation that we would get from Hume, just as an image.
Yeah. No, great. That would be great.
So let's see. I got here. So do you see this? This is like the billiard ball table. And of course, the A and the B, that is what we can observe.
Yeah.
And what we cannot observe is the arrow. And this is what the Bradford Hill criteria are also trying to pin down. So, okay, we have two events. We have a treatment, we have the recovery, for instance, or we have a treatment and we have a side effect. So it depends what you're interested in.
Yeah, right.
But the arrow between, that is the real causal work. If you take away the arrow, all you have is the correlation. And of course, when you do an RCT, randomized controlled trial, what you're trying to do is to take away the A and see if you still get the B, and then you control it. So it's like you have two types of correlation. In the test group, you have the A and you have the B. And in the control group, you don't have the A and you look for the B. And hopefully, the effect should happen more often when you have the A. And this is the difference-making theory of causation, that if it hadn't been for A, you shouldn't get B. So the cause is something that should make a difference to the effect. And with the Bradford Hill criteria, of course, you could maybe also try to add a theory that would explain how you get from A to B.
Yes.
But for Hume, that wouldn't be okay.
Not strictly empiricist anymore. Yeah.
Yeah.
So in your work, you've written a book as part of your CauseHealth project, and I have it here. I can show your book. I don't know if that's probably going to show up the wrong way. Rethinking Causality, Complexity and Evidence for the Unique Patient. Tell me a little bit about why you think that causality needs rethinking.
So one thing that happened with the Humean concept of causality is that we assume that the same cause should always give the same effect in the same type of circumstances.
Yes.
And of course, when do you have the same type of circumstances? In theoretical physics, you have it in your model.
Yeah.
But it's just because it's the same model. So you could always say like, okay, if you drop something where there is no air, no other forces, you know, it should behave in this way and it would be perfectly predictable. Once you do something in the lab, you know, in the lab setting, you have to shield off all of these interfering factors and you try to reproduce or replicate exactly the same kind of conditions many, many, many times. Even in the lab, when you go from one lab context to another lab context, there will be some things that are different, you know, so you won't get maybe the same effect. And if you take that out of the lab and into people, we already know that the context is never the same. Everyone is unique. If we think of genetic setup, if you think of the life history, your lifestyle, your diet, all of the things that could affect what happens to you, it is definitely unique. So what do you do with the concept of causation that only works under the same conditions? So what we did, so this is the work I did before with Stephen Mumford. We wanted to have a theory of causation where we could also talk about causation for the messy reality. So it's a different type of concept that starts with what Hume didn't want to talk about,
Right.
the things that we cannot observe. So there we go from what we call the epistemology, which is what we can know, to what is actually there. And we say, okay, so one thing is what can we know of causal relationships? Another thing is, if we're going to ask that question, how do we get knowledge? We first need to ask, what exactly is it going on? Is it that is going on? So what is causation?
And what are we trying to get knowledge of, right? What are we trying to get knowledge about?
Yeah, because if you want evidence, the evidence should match what it is.
Yes.
So if it is a difference maker, then you should find the difference maker. If it is a correlation, then you should find the correlation. But if it's something else, then you should look for something else. And what we're saying is that all causes, they happen because there are properties, things happening between the treatment and the person. So for instance, you wouldn't just say that if a paracetamol removes your headache, you wouldn't say that, well, the only evidence you need of this is that you take it and the headache goes away. There would have to be something in the paracetamol that has a causal power or a disposition or a property that makes it possible for it to interact with you. So you also need to have certain properties or dispositions that are receptors for the paracetamol in order for your headache to go away. So you would have to say there is something intrinsic going on underneath, explaining the type of relationship that you can see on the surface. So we actually say that the world is full of these types of dispositions. So we relate to the world in this way. We know that, so for instance, I have a glass of water here, a cup of water. I know this is fragile. I also know if I drop it on the floor, it's going to break and the water is going to spill. So I'm very careful. I won't do that. And Hume says, why do you think that? The only thing you know is that similar things have broken in the past elsewhere when they have been dropped. Okay, so for him, it wouldn't be knowledge until it is broken. So you would have to wait and see. But what we're saying is that, no, actually, these types of dispositions is what we need to have knowledge of. And if we have knowledge of how they work, then we are able to predict how they would tend to behave in other types of circumstances. But then we also need to know what it's interacting with, because if I drop this and I have a very thick carpet, it's not going to break because the soft carpet is very different from, for instance, if I had tiled floors that are really hard, it would shatter into a million pieces. So we know that how things interact and how high it falls. If it falls only from this height, it's not going to break. So we have to think not only of the dispositional properties of the thing itself, but also the contextual dispositions.
Yes.
And there we say, actually, you end up with the case where when causation happens, it doesn't depend on similar things happening elsewhere. It only depends on what is here and now.
Right.
You know, so it means that for Hume, there wouldn't be possible to have a unique case of causation. He even says, if the creation of the universe happened only once, it couldn't have been caused. Because how can you call it causation without constant conjunction or perfect? It has to be regularity.
Yes.
But what we're saying is that, no, if there were the type of dispositions involved, it was caused.
Yeah.
How you get to know of it, that's a different kind of thing. But what we say is that in order to get causal knowledge, what you should aim at is not necessarily to count how often mugs or cups break when you when you drop them. That's not how you get causal insights. That type of causal insights is not going to give you enough information to tell you what you should do. So what you need is to have theoretical mechanistic knowledge of the kind of properties involved and how they interact. So it's it's a different type of causal insights. In the Humean perspective, you would see many, many repetition and have very good correlation data and sophisticated analysis of them. And it would give you something like, okay, if I drop it, it's a 70% chance it's going to break.
Yeah.
But then you might think, yeah, but okay, so how would I know the 70%? Is that given the assumption that the floor is hard, the height is tall, and that it's very fragile and not made of plastic? Or is it just in general we have been dropping things and seeing how often they break? Because we also know that, I mean, I can drop these and they won't break that easily, so it's not like just the intervention and just the outcome is the relevant thing. It's like, what type of thing is it that we do this intervention to? And the same thing we would say when it comes to medicine. It's crucial that if I'm going to give anyone a treatment, I need to first of all know, how is this treatment working? What is the causal powers? What is the dispositions? And who is this person receiving it? Is it someone who is a relevant, what we call mutual manifestation partner? Or is it someone who might not get the benefit, but only the harms? And from our perspective, the way that we go now in medicine, where we first of all look at the statistics, is that all we really get is things like number needed to treat, and numbers needed to harm. And then I'm supposed to be able to tell you that this is really safe and efficient for you. There is no problem with side effects for you. But is that just based on numbers? Because you might be a person who has a very strong disposition towards a side effect, for instance.
So that's it means that the way that we investigate causation in healthcare becomes, it gets a bit more complex, doesn't it? Because instead of just investigating regularity, when we give this treatment or this intervention, then this outcome, we expect this outcome in this percentage of patients. What you're saying instead is that we have to design ways of investigating what's actually going on, or think of ways of investigating what's actually going on to uncover those dispositions, to work out how things are actually working, so that we can say with greater accuracy for a particular patient with their particular circumstances what that is likely to do for them.
So you see, if I went for the Humean approach, I would just say that I can fix all of that. All I need is to have very good or perfect correlation data for each subgroup. And then I would know what is best for you. And this is what you might think is the best way. So for instance, if we do a randomized control trial and we see that, it works for these 60%. Now maybe these 40% and some of them were really harmed. Maybe if we try to classify them and then we do another trial. But of course, you cannot ethically, you cannot do a trial where you know that these people are at risk. But of course, if you didn't have any ethical considerations, what Hume would say is that perfect correlation data would tell you everyone who would get this outcome, and then everyone who didn't have, so maybe if A then B, but if A and C then D, you would just get very, very good subgroups. So what we're saying is that, you might think that, but within every group that you investigate realistically, there will be outliers, there will be marginals. So eventually, if you try to predict, if you belong to this group, you should have this outcome. And then you see someone who didn't get the outcome, you would have to say, okay, so clearly there was something that was causally relevant that we didn't know. That means that you belong to another subgroup. And then in the end, we are all just unique with a lacking twin. So if we had a twin, then what happened to them should have happened to us. Not really, because twins will still have different lifestyle and different, but you can see that theoretically and methodologically, it would be great if we were all clones and our lives were clones, and at least that we could fit neatly into subcategories. But from a dispositionalist perspective, we would say that having all these subgroups is still not going to be enough to tell you the potentials of harms or the potentials or benefits. You still need to understand what it is that your treatment is doing and who it is that is going to interact with it. Because you might say secondhand smoking causes lung cancer. Okay, We know that not everyone gets lung cancer. So definitely it's a difference. But we also know that an ashtray never gets lung cancer. Because it's not a mutual manifestation partner to get it. So
it doesn't have the same dispositions at all.
Exactly. So it's not about just looking at the correlation, it's about looking at who is it. So to have causal knowledge is to understand how the properties of the treatment is working and how the properties of that person getting it is working and how they would interact.
Yeah.
And of course, this is going to be hugely complex because what you need to understand is the kind of things that could interfere with the treatment. And what they do is that they learn this from, well, actually when it fails. Because in the trial, very often you would exclude people who are at risk.
Yes.
You also have to exclude people who have many types of problems because they use many drugs.
Yeah.
Because if you if you think that if it hadn't been for this treatment, the effect shouldn't have been removed, and you go on many drugs, how do you know which one is having the effect?
Yeah, that's about removing confounding factors, isn't it?
Yeah. But in reality,
comorbidities and all of those kinds of things. So it makes it.
But once you start giving the drugs out to people who weren't in the trials, they will have a lot of these confounding factors.
Exactly.
And that's where you really learn about the causal interactions that are going on, the potential causal interactions that were there, but they were not manifested in the trial because you had excluded as much as you could.
Yeah.
Old people, sick people, children, pregnant women, you know. So actually the risk is removed in the trial. But once you start giving it to people, all the risk factors come back in, but all the evidence that you have available is going to be based on the case where it's quite efficient. So it's quite effective and it's quite safe.
Yeah.
So then you need to factor back in. But if you don't do that, then you start giving it to the old, to the sick, to the young. And then you see the complex interactions. And then some people might have a unique response. And you might say, but it was just one person, who cares? But we would care because we would think, oh, here's a new type or new set of dispositional properties that interacted with the treatment or potentially did. We should really investigate in depth what went on here so we can learn more about the mechanisms of the drug. Yeah. And maybe biological mechanisms. And a lot of biomedical insights have come from these types of failure cases. Yeah. But very often we just count them to see if there are many enough to put it on the label.
Yeah, so this is part of the challenges of trying to apply that knowledge which we get from big randomized controlled trials to that unique patient, isn't it? So, which is the model of evidence-based medicine.
Yeah, so people have said that they want more person-centered approaches, but very often this is considered to be a purely ethical, clinical dimension of it. It's not something that goes down to research. Right. So you are still informed by the same type of correlation evidence, but then you think of the person's preferences or you treat them as nicely as you can when they come to your clinic. But what we want person-centered healthcare and person-centered medicine to mean is that it's also focused on the individual in the research and that the clinic actually informs research. So you get new research hypotheses from the clinic.
Yes. Yeah. Great. Well, we might leave it there for today, but Rani, I'd love to get you back again in a few weeks' time when we look at evidence-based medicine in a little bit more detail, because I think it would be really great to explore that with you as well.
Well, it's my favorite topics, so I'm very happy to come back.
Great. Oh, thank you so much. It's lovely to see you.